Thank you, Dr. Bornstein. If you have questions, please come to the mic and give your name and institution, please.
Hi, Lynn Goldman, George Washington University. I have a question about the data when you present. I think I understand the unintentional use as being somebody who takes a drink out of one of these beverages and it was somebody else's, like a kid gets it or something, and people are called because they're concerned. But the misuse, the product misuse, I don't really understand what that is. How do you define misuse of these products and compared to the intended use?
So those are very good questions. The misuse would be if a product that says maybe use only once a day. So misuse, can you all hear me now? So misuse would be a direction, say, don't use more than, say, twice a day. Somebody maybe uses to be twice a day, to be three doses twice a day, or uses 2 doses at one time when it says only consume a unit dose. The abuse would be to get high. People would use it for a pharmacological say effect to become intoxicated.
Yes.
Dr. John Higgins, the University of Texas. Alvin, wonderful presentation. Thank you. I had a question in terms of the reporting. Does your reporting include reports from individuals just, come home or discover some problem or some side reaction, as well as the emergency department doc, who sees a patient in the ED and they report? Does it include both of those, the data you presented?
Oh, yes, it does. It includes both calls from the general public and calls from healthcare professionals. Typically, healthcare professionals call from the emergency department.
And are both of those going up in parallel on your data? You just showed one line. I was just interested.
In general, for all substances, calls from emergency departments continue to go up. And we didn't look at that specifically in this particular data run, but that's something we can definitely do.
Okay, and I'm a cardiologist, Alvin. So in our area, when we were looking for a while back more information about myocardial infarctions, and not all emergency departments, et cetera, were capturing the data and reporting, we actually set up a registry. And now there's a very well-established registry within the United States such that, anyone who's having a myocardial infarction, this will be well documented. You mentioned in your data, that they're probably underreporting. Do you think having a nationwide registry to track exposure and effects of energy beverages may be beneficial in terms of getting closer to the actual real data?
Absolutely. I think we have the beginnings here because on 95% of the calls, we'll get a phone number. People are very hesitant to give addresses. They will give us names, phone numbers, and zip codes. So if this was structured, it would not be a stretch of the imagination where these people, the callers who call the poison centers, they could be phoned back and given the option to be put into a national registry, just like you described.
Okay, so you think a national registry would be very helpful in getting a more accurate information on the problem that we have with energy beverages?
I think so, because these calls are acute exposures.
Right.
So
okay.
This would be very helpful for getting at exposures, to be chronic exposures, and to see what really happened to the person as time went by. We do get some repeat callers, but what you're describing with the infrastructure is definitely doable.
No, I thank you, Alvin, because I know in Texas, we see children presenting to the emergency departments, and oftentimes they'll say that, many of their friends have had problems, but of course, we have not heard about those. So I agree with you. I think a national registry would be a great idea.
Thank you, Dr. Higgins, and thank you very much, Dr. Bronstein. I know we have 4 or 5 people standing here waiting for to ask questions in consultation with the organizers and leaders. The next speaker is in a different format. It's a WebEx speaker and is waiting. And I was instructed that we unfortunately need to move on so we don't lose that connection. I apologize. There might be opportunities later during the discussion section. I apologize sincerely, but I have to cut this off. But again, thank you, Dr. Bronstein. Our next speaker, who will be coming in by WebEx, is Dr. Ashley Roberts, who's the Senior Vice President in the Food and Nutrition Group at Intertech Cantox. And in this capacity, Dr. Roberts is available to advise and assist international clients with issues that are scientific, regulatory, and toxicological in nature. And he's able to assist in design and development. And prior to working for Cantox, Dr. Roberts worked in the area of scientific and regulatory affairs for multinational food company, and he's an expert in GRAS and other areas. Dr. Roberts was specifically asked for the purpose of this meeting to address us on safety assessment of caffeine in foods and beverages. I'd like to ask Dr. Roberts to join us at this time.